just going to give a few more minutes for the participants. So if you could just stay with me for a few more minutes while we just wait for everybody to log on. Thank you. Hi, everybody. I think we can get started. I just want to start off by welcoming everybody who's taken the time out to join us today. Thank you so much for being here. My name is Samantha Morn. I am the project manager at the Rural Health Advocacy Project. And I'm going to be facilitating today's session. Just make sure everything runs smoothly and that everybody knows what they're doing and when. So yeah, just on behalf of RAP, I just want to say thank you so much to everybody who's joined us. Thank you so much for our presenters who are going to be presenting today. Our hopes for this session are that we can come away with a better understanding, not only of the problems around early pregnancy in South Africa, but also some of the potential solutions and things we can put in place to help young girls navigate this very complex issue. So today, the Rural Health Advocacy Project will also be launching our policy brief, which is entitled Rural Realities Navigating Early Pregnancy in Vulnerable Communities. After that, we're going to have a number of other presenters from various backgrounds with expertise in this field who are going to just be expanding on some of the issues around this important topic. So we're hoping for some meaningful discussion after each presenter. There will be time for the audience to ask questions, and you can do that by either raising your hand or by popping the question in the chat box. The RAP team will do our best to make sure that all the questions are attended to within the time limits, obviously. But yes, please feel free to engage with the speakers as well. So thank you so much. And without further ado, I will introduce our first speaker for the day. Celine Coleman is from the Rural Health Advocacy Project. She's a junior researcher at RAP. She has a background and passion in feminist studies and particularly focused on menstruation, contraception use, and gender studies. In her work, she aims to promote both understanding and increase advocacy in these critical areas. Celine will be presenting on our policy brief. So over to you, Celine, to tell us about navigating early pregnancy in vulnerable communities. Celine, you need to unmute.
Can everyone see my slides? We're good? Okay, perfect.
Yes.
Thank you so much, Sam. Good afternoon, everyone. Today, I will be taking you through our newly launched policy brief entitled Rural Realities, Navigating Early Pregnancy in Vulnerable Communities. So 2022 saw 13% of adolescent girls give birth before the age of 18 globally. During the same period, Sub-Saharan Africa had one of the highest birth rates of 99 per 1,000 girls aged 15 to 19, which was more than double the world average of 42 per 1,000 girls. The overall increase in adolescent birth rates, combined with the increase of pregnancy rates, which I will unpack shortly, indicates the need to address the issue of pregnancy prevention amongst 10 to 19-year-old girls. In 2024, South Africa had a birth rate of 40.7 per 1,000 girls aged 15 to 19 years old. In the younger age group of 10 to 14 years old, the birth rate was much lower at 10 per 1,000. According to the District Health Barometer, in 2018 and 2022, there was an annual increase in deliveries in faculties, resulting in an average increase of 6% per 10 to 19-year-olds. In 2021 and 2022, this then decreased to about 5%, yet the overall trend is still on an increase. The District Health Barometer also assisted us in recognizing that the 10 districts with the highest delivery in faculty rates for 10 to 19 years old between 2022 and 2023 were actually all rural districts. Of the 20 worst performing districts for this indicator, 19 of them were rural. 7 of these were found in KZN and 6 in the Eastern Cape. These findings give us a really strong motivation to prioritize pregnancy prevention for adolescents, particularly in rural areas. Adolescent pregnancy rates also increased from 26.8 per 1,000 in 2017-2018 to 30.5 per 1,000 in 2021-2022 for girls aged 10 to 19 years old. The proportion of pregnant girls aged 14 to 19 also increased from 2.7 to 3.8%. However, this is still lower than the previous years. According to the analysis of data from a 2016 community survey, our pregnancy rates for 15 to 19-year-olds were higher in rural areas than what they were in urban. The Department of Basic Education's analysis on the General Household Survey of 2019 found similar results, that rural provinces such as Limpopo and Mpumalanga actually had the highest pregnancy rates compared to urban areas like Gauteng and the Western Cape. So there were several reasons why we felt that this policy brief was of importance, but some of these reasons include understanding why early pregnancy occurs to help develop and strengthen current programs. So we seek to increase access to sexual and reproductive health services for adolescents, particularly for those in rural areas, as we've previously highlighted. We also recognize the impact of socio-cultural factors. Hence, we seek to explore ways to provide social protection for these adolescent girls. Lastly, our policy brief simply wanted to make recommendations to reduce pregnancy and birth rates in adolescents, as we recognize the major impact it has of different levels in society. We then looked into literature, where we found that many pregnancies in adolescent girls are unwanted. A South African study showed that 8.3% of pregnancy terminations actually happened between 2017 and 2021. This gave us evidence that there was a big issue of unwanted pregnancies amongst teens. Hence, we asked ourselves, why are these pregnancies happening? And we found 3 main issues. Firstly, being a supply side, which focuses on the issue of contraceptive access in South Africa, which South Africa has been experiencing quite often, specifically after COVID-19. There was also a decrease in the distribution of both male and female condoms. Regarding demand side factors, this refers to the inconsistent or incorrect use of contraceptives, as well as poor contraceptive uptake. These issues are associated with unfriendly healthcare services, the use of stigma and discrimination by healthcare workers, friends, families, and other institutions. Lastly, socio-cultural economic factors. These factors included social coercion or pressure from male partners, lack of parental communication and support, or poor parenting in the household. Also, lack of employment opportunities and school dropouts led to unwanted pregnancies. So some of these problems have actually been recognized, hence like non-governmental organizations launch programs that include sex education, peer education, mass media, and clinical initiatives. The most effective programs launched actually reinforce career aspirations, and research has shown that educating children on the consequences of unintended pregnancy are also of major importance and actually had a really big impact. So then literature also highlighted the impact of early or unwanted pregnancies. And here we found that globally, maternal conditions are amongst the top 5 causes of both death and disability adjusted life years in adolescent girls. 7 girls of 100,000 face maternal conditions, which was the second leading cause of death for girls between the ages of 15 and 19. Teenage pregnancy was also a leading cause of girls dropping out of school in South Africa. A rural Bushbuckridge study showed that almost 16% of girls between the grades of 8 and 11 fell pregnant during the time the study was conducted. The study showed that pregnancy made girls 2 times more likely to leave school. However, if they did persevere and stay in school, they were most likely to have to repeat a grade or had really poor school attendance. Both these implications of pregnancy show poor school performance and ultimately reduce the likelihood of these women successfully entering the job market. Then economic impact showed that there's an economic burden of childcare costs affecting marginalized rural communities more in like pre-existing poverty communities than urban areas. On a governmental level, more childcare grants and healthcare subsidies will be needed to help these people with unintended pregnancies because of their lack of educational background, ultimately placing a greater financial burden on public resources and negatively affecting economic development in the country, where already 13 million rand was spent on child grants between December 2022 and March 2023. The fact that teenage pregnancy results in stigma is well known to us all. However, this societal stigma also results in internalized stigma, such as feelings of shame. Thus, most pregnant teenagers lack getting or seeking emotional support. Discrimination was also faced at school as well as in the community. At school, the Bushbuckridge study actually revealed that teachers were stigmatizing, leading to the dropout rates that we've previously discussed. Within the community, mothers faced a reduced status at home and in the community because they felt rejected and often faced violence from their family members, peers, or even partners. And in some cases, they were actually forced into early marriage to preserve an image. So we've made several recommendations to combat early pregnancy, but for the purpose of time, I'll just discuss these relatively briefly. To make sexual and reproductive health services more accessible for adolescents, we need to take a few critical steps. First, we should conduct surveys and focus groups to understand directly what adolescents need from adolescents themselves. Next, we should train youth-orientated healthcare providers who are relatable, not judgmental, and skilled in counseling, as this is essential to offer appropriate counseling services that actually guide adolescents in their sexual and reproductive health choices, providing a safe space for them to actually discuss these sex-related topics. To improve adolescents' access to contraceptives, we suggest the need to explore the feasibility of providing contraceptives at school. This step would significantly increase access, specifically for those in rural areas, and help normalize the service, reducing the stigma and letting education support the process. Additionally, we should explore other contraceptive access points based on the feedback from the surveys and focus groups from adolescents themselves. And having consistent access to contraceptives in clinics is essential. This means that reducing stock outs, particularly in vulnerable communities, and ensuring that all counseling sections actually have discussions of alternative contraceptive options should supply issues become an issue again in the future. To increase the demand of contraception, we should educate both male and female adolescents through school and various media platforms like social media, community radio, where we can encourage the uptake of contraceptives by involving like role models, community members, celebrities and sports stars, and even like media campaigns just to advocate about the use of contraceptive use as well as availability. Additionally, we need to increase the access and awareness of adolescent rights to healthcare, such as independent access to healthcare, and their rights to continue education if pregnancy should occur. Furthermore, education and counseling on the implications of early pregnancy should be provided in schools as well as healthcare facilities. And this education should include a positive focus on career aspirations and the potential of each individual. To better support adolescents facing stigma, we should increase awareness of their rights, educating health and education providers on these rights to improve support for ongoing education during pregnancy and enhance access to reproductive health services. Additionally, we need to emphasize the shared responsibility of both genders in combating unwanted pregnancy and the use of barrier methods. Providing communities with relevant data and statistics through media campaigns will also foster an understanding and an awareness of the social contexts that are actually impacting adolescent girls. To effectively support our adolescents, we should also foster collaboration between departments, such as the Department of Health, Education, and Social Services. This partnership will help us achieve the key recommendations, but also enhance sexual and reproductive services and access of these social determinants like poverty and rural living that put adolescent girls at risk currently. By working together, we can create a comprehensive support system that addresses both the immediate needs as well as the factors underlying youth. So in conclusion, early pregnancy in South Africa remains a pressing issue still, particularly for our rural areas. Despite various initiatives, we continue to see a relatively high birth and pregnancy rates amongst our adolescents, indicating the need for an enhanced prevention program. Addressing these challenges is crucial to minimize the severe impacts and consequences of early pregnancy, such as increased maternal mortality, school dropouts, and economic burdens. To truly succeed, we need a multi-sectorial approach that integrates education, healthcare, and social welfare. Together, we can actually make a difference in tackling early pregnancy in South Africa. Thank you so much for your time.
Thank you, Celine, for that very interesting presentation and for just highlighting all these really important issues around early pregnancy. I'm just going to open the floor now for any questions that the audience might want to ask. I see that there is one already in the chat. I don't know if you've had a chance to have a look at that, Celine.
I'm doing that now quickly.
So it basically says, is it wise for the health department to enter schools and distribute condoms or contraceptives, seeing that we have a lot of unintended pregnancies in high schools leading to dropouts increasing rapidly?
Okay, Mr. Anonymous. As RAP, I think we definitely do see the need for this integrated approach between the different sectors. And like I said, if we're going to have the health departments in our schools, it's going to reduce that stigma of taking contraceptives is bad, and it's going to make it a very normalized situation amongst teenagers. Reality is we can't necessarily stop teenagers from having sex, but we can stop their unwanted pregnancies. And I think that happening in the schools will definitely reduce the stigma, but also normalize being on a contraceptive.
Yeah, and just if I could add to that, I think that, one of the things that we were just saying in our recommendations is that we wanted to explore other avenues of increasing access to these things. So it is definitely an avenue that we think is worth exploring. I've definitely, on a personal level, even heard stories of young girls being turned away from health services. And so, that's also part of why we wanted to have an increased awareness of the legislation that guides their ability to access health services at their age. So that was definitely was one of the strategies we thought would help to increase access. I don't know if anybody else has any questions that they want to put to Celine.
Juliet has a hand up.
Say again?
Julia has her hand up.
Oh, go ahead, Julia.
Yes, thank you. Thank you so much for your presentation. I just wanted to add a little bit more on that question of anonymous. So we have a policy with a basic education that we can actually enter a school facilities and give education and offer a contraceptive methods. But the problem become complex because the school system doesn't only have the teachers, the principal, and the pupils. So we have school governing bodies, we have parents, and we have different value systems. So that becomes a barrier because in certain schools we can actually enter, but then other parents would actually strongly feel that we do not allow this to happen. So I think our education should actually be more in communities, and the school governing body should also be made aware of the fact that the law allows that. We can't help it. I mean, they're having sex in the schools, so something needs to be done. And because they don't access our facilities, we need to actually get to them. Thank you.
Yeah, thank you, Judy. Those are excellent points. And definitely there is that need to, we saw that very strongly in the literature, a need to increase the education in the school system itself and break down the barriers that are happening from an education perspective that are, influencing the teenage pregnancies out there. So thank you for that point. Anybody else have any comments or questions on this presentation before we move on to the next presenter? Hanifa, are there any hands up that I'm not seeing?
No.
Okay, great. Good. Okay. Thank you so much, Celine, and thank you for the engagement on that question from everybody. We'll now be moving on to our next presenter on the agenda. So I'd like to introduce Judia Kanape, and I'm going to just tell you a little bit about her. So Judiak is a comprehensive district health nurse trainer and abortion provider in the southern and western substructure of the Department of Health in Cape Town, South Africa. She's the acting facility-based manager focusing on maternal and child health programs and a member of the Sexual Reproductive Justice Coalition and an Atlantic Fellow for Health Equity in South Africa. Judiak has kindly agreed to do a presentation today on some of the work that they're doing there. And her title of the presentation is Comprehensive Strategies to Prevent Teenage Pregnancy. Judiak, thank you so much for being here, and I'll now hand over to you to expand on this topic. Thank you so much. Judiak, I don't know if you've started speaking, but I can't hear you.
Can you see my screen?
Yes, we can see your screen.
Okay. It doesn't seem like I am. Apologies, I just need to unshare.
No problem. Go ahead, and then you can share again once you have navigated everything.
Ach nee.
We can see it perfectly from our side.
Can you see?
Yes, it's
We can see you on the slide 2023, 2024 termination of pregnancy and abortions.
No, but it's not visible on my side. Oh.
If it's easier, you can just present
Okay.
from that
Can you-
platform. Yeah.
Sorry, can you see my, can you see it now?
Yes, we can see it perfectly.
Okay. But you're seeing, my problem is you're seeing, okay, there we go.
If someone else has the presentation, then maybe they can share it and Judy can still present.
Okay. Can you see the main slide? No.
Yes, we can, yeah.
Can you just tell me which slide are you seeing there now?
It says the number of contraceptives used
No.
nationally.
Okay, let me send it to you quickly.
I think in the meantime, if you just want to present, you could just present from this platform without having the slideshow. And because I think we can still see the slides, so you can just go through it like that, if that's easier.
Oh, no.
Otherwise, there we go. It's going
There we
through.
go.
There we go. Well done.
Okay, I am ever so sorry. Okay, then. So teenage pregnancy often implies that the pregnancy is unplanned, and Celine has covered most of the things. This is marking a significant crisis in the lives of adolescent and young girls. And these early pregnancies can prevent them from progressing during some of their most important years of their lives, affecting their education, personal development, and future opportunities. Now, gender-based violence in this age group is a major contributing factor to these early pregnancies, compounding the challenges faced by these young girls. Because I've had to, just in the year 2023, 2024 financial year, performed numerous abortions of girls as young as 10 years old that were actually raped. So teenage pregnancy obviously is associated with an increased risk of pregnancy complications like maternal death, unfinished education, reduced opportunities for socioeconomic advancement, higher infant mortality rates. Congenital syphilis is our biggest challenge in all our primary healthcare facilities at the moment because our teenagers are just having sexual intercourse without condoms. And we've been having notifications since the beginning of January that every other month we have almost like 9 to 12 teenagers who are giving birth to children who have congenital syphilis. And the biggest challenge that we are having is that at the moment we are having a shortage of Bioselin, so dealing with that, it's a big problem. HIV infections are actually on the rise. There's drug and alcohol abuse, and depression and mental health issues are also one of our biggest challenges. Now, the causes of these teenage pregnancies, obviously, it's a lack of sexual and reproductive health, education. So talking openly about sex and contraception is still taboo in many rural and urban communities. Cultural influences with deep-rooted gender norms limit girls' autonomy and decision-making power. Our girls cannot negotiate the use of condoms. They are not in a situation where they can say no when it actually matters most. And this actually leads them to get into a lot of trouble. There's misinformation and lack of access to sexual and reproductive health services and job access. And in my portfolio, the biggest thing that we are seeing throughout the country with this issue is because we have very few healthcare providers who are trained in contraceptive and fertility planning training. It might seem like an easy thing to say, you can be family planning trained. But for you to can actually deal with the side effects and break that issue of women or girls shying away from using these contraceptive methods that are giving them problems is actually a big thing. There are not even basic antenatal care facilities, especially in the rural areas, where these young girls who find themselves pregnant can actually attend care because they have to travel, because the 8-hour facilities within the villages do not have basic antenatal care to offer. Celine has already alluded to the fact that we have high dropout rates, particularly among girls due to economic pressure. But another thing that we have also identified is the fact that in the rural villages, you have like the primary school and the middle school sector. And then you find high schools which are sparsely located within these villages, meaning that when these adolescent girls come out of the middle school, ready to get into high school, they have to probably go to another village. They must go and live probably in that village, or they need to walk distances to get there because there isn't money for transport. And that's where the challenge comes, because the family dynamics become broken. The care and supervision is often diffuse, leading to less direct oversight on these teenagers. Because if they live in another village, anything can happen. They get engaged into these sexual encounters. They do not take accountability to what is happening, and they actually find themselves pregnant. So that's an issue that we're battling with at the moment. We also have the need to, they also have the need to keep up with the outside world for material things. And because of these broken family dynamics that we are still having, whether it's in the rural or in the metro areas, there is a very deep need for love and a feeling of belonging. And without thinking, the teenagers actually get engaged in these things. Gender-based violence is our biggest issue at the moment, and transactional sex is even worse. And it becomes even painful because me as an abortion provider, if I have a 10-year-old coming to my consulting room seeking an abortion with the parent, I am obligated to actually report. But then you will have the parent that says, but we rely on this man that is actually paying the rent or buying us food to actually have sex. So society on its own has got challenges, and they are the cause of us having this escalation with the teenage pregnancies for economic reasons. Obviously, it's been alluded to the fact that there is limited access of contraception and healthcare services. These are the total number of deliveries that we had in our maternity outpatients units and the hospitals. This doesn't include our tertiary hospitals. This is throughout the country. That is a 2022-2023, and that is 15 to 19 years. As you can see, KwaZulu-Natal is actually leading, followed by Gauteng, the Eastern Cape, Limpopo, and Mpumalanga, and then the Western Cape. Then in the 10 to 14 years, we still having KwaZulu-Natal that is leading, the Eastern Cape, Gauteng, Limpopo, Mpumalanga, and then the Western Cape is also following after that. And I'm particularly saying this because in my next slide, you will actually see the contraceptives that are actually being offered in our public health sectors. And it was quite interesting for me to actually see that right now we are working so hard to promote long-acting reversible contraceptive because the uptake is very, very low. And as you can see on the slides there, we are having provinces where they're actually giving over 1 million of the injectables. And we all know that when you introduce progesterone into a woman's body, there are side effects, and some women have them more than others. And the management of these progesterone side effects is not actually done well. So this actually leads to girls and the adolescents actually defaulting or stopping the method, leading to unintended pregnancies because they have issues like putting on weight because not in a proper history taking was done, or they're not supported well, loss of hair, losing weight, having issues with their skin, because the World Health Organization MAC wheel was not provided properly for them to can actually choose a proper contraceptive for them. If you can look at the female and male condoms, this is actually quite a sad story. So because we rely on conditional grants to buy contraceptives in South Africa, this is actually so it is expected of us to actually document what is being given. So large amounts of male and female condoms are actually distributed, but they are not used consistently and correctly. And when you go on the ground and actually interview these young girls or even the women that are using, the weirdest things are being used for these condoms. They clean their shoes with them. They do not actually use them properly to actually prevent STIs and pregnancies. With a female condom that has a sponge, the women actually take out the sponge to use it for makeup on their faces. And yet we are documenting that we have distributed over 1 million condoms, and then we wonder as to why we are having challenges with teenage pregnancies, because these things are actually not being used properly. This particular slide actually only pertains to me. So in the 2023 to February 2024, these are the total number of abortions that I personally performed on girls 10 to 14 years, which was 64, 15 to 19 years was 612. That was a total of 676 that were done. And so the medical abortions alone was in the entire metro of the Western Cape was 3,280. And the surgical ones was 3,161, with a grand total of 6,441, bearing in mind the maternity outpatients delivery data that I had just shown you now in these age groups, 10 to 14 and 15 to 19 years old. Now, the comprehensive strategies to prevent teenage pregnancies are actually quite doable, and we are actually trying to implement them right now. So sexual reproductive health education, as I had said to you earlier, the Department of Basic Education says healthcare providers can actually come into the school. And within the life orientation period, it is allowed for our school nurses to can actually enter and properly do the menstrual cycle, properly deal with issues like masturbation, changes with body issues, and how and sexual encounters of the adolescent and youth. But unfortunately, there are barriers, and we are working on it. We should work even harder on that, because it is expected for the educators to just do life orientation out of the book. But we have seen now it is not effective. We are having issues where girls and boys in certain schools have sexual intercourse in the toilets during break times, where the educators actually tell us that they don't sit in the staff room during break time. They actually go to the toilets so that they can make sure that nothing actually happens in them. Age-appropriate, culturally sensitive, comprehensive sexual education should be available in school. We should be engaging with parents and communities in having open conversation about sexual health. Like I had said earlier in my comment about with Anonymous, is that we need values clarification and attitude transformation of parents and communities. Because as much as we are trying to deal with the fact that we are having young girls menstruating at 8 years old with a possibility of can be able to fall pregnant as an adolescent at 9 years old, it is high time that we do values clarification, that we do not have communities and parents still expecting these girls that are maturing to be acting otherwise, but to actually acknowledge that they are in trouble and we should openly talk about this. We should actually be able to can deal with all the myths about the fact that sexual education is going to encourage them to have sex. And this can be achieved by having imbizos, calling the chiefs, the indunas, and all the matriarchs in the communities to actually educate them about this so we can start having open conversations. We should also ensure the availability and accessibility of contraceptives, and not only the availability, also using the medical eligibility criteria of WHO. No use us pumping 1 million worth of injectables to adolescents and girls that are going to stop because of side effects. If they choose to become sexually active, and we can insert an intrauterine device that does not have hormones, why not go that route? Instead of us just documenting that we gave 1 million, but the results do not show. The couple-year protection rate is not achieved, and we're having this increased number of adolescents and youth that are actually falling pregnant, yet we are documenting that we are giving them contraceptives. We need to train and sensitize healthcare providers so that they can offer non-judgmental and confidential services. Once again, values clarification and attitude transformation workshops are important. We should go on a drive throughout the country to do those workshops, because what is confidentiality in health and social care? And if that is not enforced, then we are going to have a challenge. Empowerment and life skills training need to become even more by working in collaboration with all the funded and non-funded non-governmental organizations and channeling them to where they are needed most. They are saturated in the city, and yet the adolescents and the young girls in the rural areas do not have these, and yet there is funding that is available. We also need to provide these workshops to build self-esteem and decision-making abilities, but not going away from that, also dealing with faith-based organizations and traditional healers so that we can have all hands on deck to can deal with this teenage pregnancy scare. We should offer vocational training and educational opportunities to keep teenagers engaged in their future. This might just seem like a dream, but we have organizations like Love Life and Soul City who have shown us that they don't have clinical services, but they have the funding, they have the skills, they have the people. And if we work with them together, we can actually engage and channel our teenagers towards the right path. We should also involve teenagers in decision-making processes in healthcare services suitable to them, and follow onto the slogan that says, nothing for them without them. We should involve them. We should educate them, involve them, and we should also make them aware what can work for them, what is rightfully theirs, and how they can easily make a conscientious choice on that. Establishing youth-friendly health services is actually on the cards right now. And there's a lot of ways that can be done, because right at the moment, our facilities cannot deal with the growing populations that we are having. In all our facilities, from the morning up until lunchtime, we are dealing with the bottlenecks of acute and chronic diseases. And young girls and adolescents that need to access that, so they are not sick. There's no need for them to be sitting all day to come and access an emergency contraceptive pill. But we have these issues There are no extended hours. In our 8-hour facilities, there are no services that are running. Weekends, you can hardly, we are focusing on emergencies that are coming in. But we've taken a different direction to go into community hubs, to go into the halls, to train our community health workers, because our community health workers live in these communities. They know them more. The youth and the adolescents engage with them. And when we orientate them to what adolescent youth-friendly services are all about, what is needed, what are the danger signs that can be identified, they can actually see them and they can channel them appropriately into the care that they need. We also need to integrate mental health care services to address lots of issues like depression and anxiety, because as I'm sitting right now, issues regarding sexual reproductive health and mental issues, or young girls that are not coping with the fact that they had to go through a traumatic procedure like a surgical abortion, they do not have access to mental health because it is meant that it's something that they went through. They must get done with it and move on. But they are not being seen to in our mental health care facilities by our mental health care nurses. It actually takes a child to completely break down to can be assessed, managed, supported, and even medicated later. Community and parental engagement is very key to overcoming this crisis, working with parents and caregivers and faith leaders. And I've just picked up not so long ago where we dealt with faith-based organizations, but their key was go according to the Bible and use abstinence. But we came in and we said, yes, we will preach abstinence, but on top of that, if the adolescents and the teenagers choose to have sex, let us give them an option to actually choose. We should also encourage community leaders to support initiatives aimed at reducing teenage pregnancies. And like I already said, effective communication regarding sexual health, it is so important. It's mind-boggling to find that in this day and age, we engage with parents who are still not comfortable talking about sexual health, and they want to push it away to the school. And yet we are saying that the teacher has got too much to deal with for the teacher to now still be engaging with things that communities can actually deal with. We need to provide comprehensive support for teenage mothers, including education, childcare, and healthcare, which is non-existent at the moment. A lot of our squatter camps that are springing up are actually having young teenage mothers who are sitting there, who are not doing anything with their life because they are not being supported and they can't go ahead with anything. Programs should be provided to give them a second chance, and so that they can continue with education and training, because right now they are helpless. They do not have guidance. They do not have anybody that can lead them to the right direction. Having made a mistake, having fallen pregnant, not being given a second chance is actually creating a doom, just a doomed future for them. In summary, all I can say, it is possible. Adolescent youth-friendly services should not be a tick box service. We should actually engage with it. We should know their needs. We should study them. Community and parental engagement should also be available. We should engage with communities. And we have seen in our fellowship that when we engage with communities, they give us a hearing, they get to understand, and they actually work hand in hand with all those who are prepared to assist them and guide them. Community-based services should be the biggest buzzword probably after COVID, in such a way that we have embarked on a way where we take community health workers, we orientate them in adolescent youth-friendly services, we dissect the adolescent youth-friendly service policy so that they can know what is expected, what is to be done, what to identify, where to refer to, and how to actually work with the needs of these vulnerable communities. And we've also identified having groundbreakers and adolescent youth champions within communities makes it easier because they know better than us. Unfortunately, in my nursing career, we are having an aging nurse cadre because of all the mishaps that happen with the training of nurses. But it's amazing the things that we learn from these groundbreakers and adolescents about what they need, what they want, how they see adolescent-friendly youth service, and what the things that we can put into place for them to can actually work for them. And if they are in the party to work with them, it'll actually be better because they spread the word better. The other teenagers and the adolescents actually listen to them. Extended cleaning hours are actually very important after school and weekends. And it is actually heartbreaking to know that within the city, in the urban areas, there are a measure put in place where the Department of Health has actually collaborated with places like Dis-Chem and Clicks to provide contraceptive measures for free to communities. But we don't have this in the rural area. So we need to be a force behind this so that we can make it a reality, because it is not only applicable to the urban areas or to those who can reach. It's supposed to be for everybody so that we can decrease the teenage pregnancies that are happening within particularly the rural provinces. Mobile clinics play a very big important roles, and we've actually seen that when we have OTLs, who are the community-based service registered nurses, even those that are retired in these austerity measures, they can actually offer this service in our mobile clinics. So there shouldn't be an excuse that we do not have the manpower. Let us take these services to those communities who really need them, because then we could curb the need for them to go walk kilometers, cross rivers and hills to actually access these services. And lastly, mental health care services is our biggest challenge that we are having. We need to have support groups, life skills programs. And at the moment, since we started 2024, we've actually been pushing these non-governmental organizations who have funding to say, help us to equip communities, help us to make them know what is rightfully theirs, help them to even know what are the laws of the countries, be it the acts, the Sexual Offences Act, the Children's Act, and so on, so that by the time they come into contact with challenging issues like the youth or the adolescents or the teenagers asking questions, they should actually be ready to can listen, to can be open, and to can be able to refer them appropriately to the right people that can intervene and direct them to the right services. And on that note, ladies and gentlemen, I would like to say it is possible. We should all join together, and lastly, I'm saying, let's start. I thank you.
Thank you so much, Juliak. That was really an amazing presentation. Just gave us such insight into what it's like delivering these services at the coalface, and the challenges and the hope and solutions that you have proposed all sound excellent. So yeah, like you say, let's start. Unfortunately, because of time, we don't really have an opening for questions, but if anybody does have questions for Juliak, please pop them in the chat and we'll try to get to them at the end of the session. For now, I'm going to introduce our next speaker. Next up, we have Jess Roussel, who's going to be speaking on the prevalence of contraceptive stockouts in South Africa. And I'm going to just tell you a little bit about Jess. Dr. Estelle is an applied political science scholar with over 15 years of experience leading advocacy and research in the United States, Asia, and Africa. Her work concerns intersections of power, in particular how it manifests through states, gender, race, and reproduction. She is the principal at the consulting firm The Just Agency, and expert advisor, Gender Justice, the Center for Applied Legal Studies, Executive Secretary, Board of Directors, Sexual Reproductive Justice Coalition. She holds a PhD in Politics and International Development at the University of Leeds, a Master's in Development Studies at the University of Rotterdam, and a BA in Asian Studies. It's amongst other qualifications. So Jess, thank you so much for taking the time to join us today. And as I said, Jess is going to be expanding on the prevalence of contraceptive stockouts in South Africa. We're looking very forward to hearing what you have to say. Thank you so much.
Thank you so much. I don't want to have the same problem. Oops, Judy did. Is it possible not to, let's see. Is it possible not to have the full screen while I'm sharing?
You're welcome to present from the other one if you prefer. Whatever you're most comfortable with. Pardon?
Say that again.
I said you're welcome to present from the not the full screen if it is easier for you.
Okay, let's see if, well, it doesn't seem to allow, okay. Does that work?
Yeah, that's fine.
Oh, great. Okay, perfect. So thank you so much for that wonderful introduction, my long laundry list. It's wonderful always to be in conversation with Sis Judy and also the Rural Health Advocacy Project. This is such an important topic. So I'm going to get into my contribution. In 2023, as attention of the public and policymakers focused on stats that showed the sharp rise in teen pregnancy that has already been discussed and shown in detail, I did a study to better understand why contraceptives have been in short supply. As was mentioned earlier, this has been noted to be one of the reasons that links to the potential cause of teen pregnancy. So this is what I've looked into. You can see on the screen, it describes a little bit of the aim and the background to the study. The study that I did compares the availability of contraceptives in 3 provinces. And it particularly provides insights into the relationship between contraceptive users, their requests for particular contraception, and the access that is available to them. The research has been guided by 3 particular questions. What was the availability of contraceptive stocks? What is the relationship between contraceptive users, requests, and availability, including the availability of abortion services? And what is common across the 3 provinces? What is unique and why? So there are several factors relating to early pregnancy that either increase or decrease a person's vulnerability, as we heard in so much detail from Sis Judy. The most important, I would argue, is freedom and safety, meaning that girls, women, pregnant people are able to make decisions to decide for themselves whether and when they wish to become pregnant, to terminate a pregnancy, or when to give birth. So as you'll see on the right side of the slide, South African law creates the legal safety and freedom as well as the access to information about sex, STIs, pregnancy, contraceptives, and abortion to ensure individuals are able to make informed reproductive decisions. However, the complexity of reproductive freedom means that these protections can be damaged by many factors, including when a person cannot access contraceptives. Sis Judy gave many examples, including discrimination, beliefs that are held by the state, by society, health providers, as well as parents, for example. The control around one's decision-making comes from many different facets of society outside of ourselves at times, especially when we're talking about people who are underage. So context, and now I'm going to get a little bit more into the methodology. So to examine these particular questions, the study used data that was collected on contraceptive and abortion availability between April 2022 and June 2023. We focused on 3 provinces, KwaZulu-Natal, the Eastern Cape, and the Northwest. These were chosen to focus on because data from the previous year, from April to June, showed that these 3 provinces had the largest percentage of contraceptive stockouts out of the 7 provinces that had been surveyed. So the data that was used is from Rashidze. I'm not sure how many people here are familiar with this publicly available data set, so I'm going to give a little bit of background. Rashidze is a community-led clinic monitoring system that's developed by organizations representing people living with HIV, as well as key populations. I said it's already publicly available, and what happens is that community monitors collect data from primary and community health centers on a quarterly basis in 12-month intervals. They're covering 400 facilities total, and those are in rural and urban areas in 7 provinces. The facilities are selected for participation based on their high volume of patients and also being PEPFAR supported. So this particular research that we've done focuses on 3 of their data collection tools: the Public Healthcare User Survey, the Facility Manager, and the Medicine Surveys. So while monitors visit the facilities, they aim to recruit 50 patients to participate in the user survey. This survey collects 14 indicators relating to contraception that is delivered at family planning clinics. So not in the maternity wards, not anywhere else, but in the family planning clinics themselves. The manager survey, each manager participates in the survey. It's either the facility manager or the pharmacy manager, as well as participating in the medicine survey. And both of these combined collect 7 indicators on contraception, mostly relating to service delivery and at the family planning clinics. I also used a literature review, and you can see on the slide the keywords that were used. We looked at government reports, academic articles, news reports, and of the 40 articles that we initially selected to review, 13 were found to be especially relevant. So I'm also going to be sharing a bit of my conclusions and findings from the literature review. So first, I'm going to go through and tell you about the main findings, and then we'll get into the particular tables, just to give you an overview to begin with. So the main findings is that in KZN and the Eastern Cape, after the first, over 5 quarters in in all three provinces, the injectable contraception was reported most often out of stock. Particularly in KZN and the Eastern Cape, external condoms were the second least accessible contraceptive. However, in the Northwest, the implant was the second most often reported out of stock. Interestingly, in KZN and the Eastern Cape, almost all women and girls surveyed did not receive the contraception that they requested. And in contrast, the majority surveyed in the Northwest did receive the contraception that they had requested. Oops, sorry, moving around with the slides here. The cause of these differences between the three provinces was not clear. In terms of the literature review, the main findings showed that reliance on monopolies of international manufacturers and suppliers of contraception, as well as poor information and data systems at the provincial level, contribute to stockouts. The literature also showed a consensus that incompatible electronic information systems, a continued reliance on manual, paper-based, handwritten systems, poor stock controls, ordering, and a lack of human resources, as well as storage for contraceptions in facilities, are major contributing factors to stockouts. With regard to the choice of termination of pregnancy, the abortion services, the majority of primary care facilities surveys reported referring users for abortion services. Importantly, in the Eastern Cape, more facilities reported abortion services are not available at all than are available on site. In the Northwest, an equal number of facilities reported abortion services are not available at all, as well as those services being available on site. So they're tied. They're either not available or you can get them right here. In KZN, over half of the facilities reported CTOP services were available on site than those who were not available at all. So you can see that there's no sort of uniform user experience. It really depends on your geography to understand what kind of service you're going to get when you go to any sort of clinic or community health center for reproductive health services. So I'm going to get a little bit into the detail of each province now. Those are the overall findings. So we're going to start here with KZN. So this first table shows the type of medical commodities that patients reported are not available in the user surveys. So in KZN between April and June 2022, you can see that 60% of the users reporting said that contraceptives were not available. While between July and June 2023, the percentage of patients reporting unavailability of contraceptives fell by 39%. So what we see is that as the quarters went on between 2022 and 2023, contraceptives were more available in KZN. Okay. Moving to the second slide now, this particularly focuses on what kinds of contraception is available and is not available according to the patients who were surveyed at the facilities. So in KZN, the table shows that contraceptives patients said were not available were injectables. They were the least often available. The injectables, of course, refer to the Depo-Provera or the net-end contraceptions, the progesterone ones that Sis Judy was talking about in terms of patients sometimes being enrolled onto them and then because of side effects, not carrying on. So the majority of people in South Africa who are using contraception are using the injectables. So the fact that in KZN, these are the least available, the least often available, followed by external condoms, shows that this is a significant problem because it's the most often asked for contraception. So moving on to the availability of abortion services, this table shows the number of facilities accessed each quarter in terms of the availability of abortion services. As you can see, most facilities referred patients elsewhere for this service, while up to 34% reported providing the service on site in one quarter. Going to move quickly through this. We're going to go to the Eastern Cape now. So the first slide again shows the type of medical commodities patients reported are not available. In the Eastern Cape between April and June 2022, 43% reported contraceptives were not available, while between July and June 2023, the percentage of patients reporting unavailability of contraceptions fell by 29%. So that's a 10% difference in terms of the improvement in KZN and the Eastern Cape in these 4 quarters. So KZN wins, and contraception was more available in these 4 quarters than it was in the Eastern Cape, and we see an improvement of availability in both of the provinces. So there's some good news here. So let's look again at what particular contraception we're talking about. This table shows the contraceptives patients said were not available in the Eastern Cape. In the first quarter, it was injectables, followed by internal condoms, were the second least often available. And in the following 4 quarters, it reversed. External condoms, followed by injectables, were the least available. So interesting. I think it's also important to note here when we're thinking about these findings that what Judy said, that injectables are the most commonly used contraceptives in South Africa, so they're also most high in demand, and how we can understand how that impacts the service and also the reporting. Okay, we're going to move here to the availability of abortion services in the Eastern Cape. This shows that 30% of those surveyed reported that the service was not available, while 54% of facilities surveyed refer to other facilities, and 20% reported that they're offering the service on site. So again, it's a very mixed experience, and it depends where you go and which facility you're at, which geography it's in. So now we're moving to the beautiful Northwest. And again, the first table shows the type of medical commodities that patients reported were not available. And here, it's a little bit different. Except for the 3rd and 4th quarters, contraceptives were reported consistently unavailable. You can see that our respondents for the Northwest are significantly less. And so we also look at that in terms of the limitations of the study, how many surveys were completed in this area. But still, it's important to note that those who were surveyed acknowledge that there is contraception consistently unavailable. So now looking in the Northwest to again, the patient's responses to what types of contraception they found unavailable. For the quarters in which there is data available, the majority of patients surveyed reported that most to all types of contraception were not available in the Northwest. So this is a grim picture. Now moving to the experience of availability of abortion services. This table again shows the availability. 23% of those surveyed reported the service not being available, while 50% referred to other facilities, and 23% reported offering the service on site. So this is a little bit more similar to the Eastern Cape when we're talking about the availability of the service on site. And now we are going to move straight into the conclusions. So this research again examined the shortages of contraceptive stock in the 3 provinces and shares insight from literature about the potential causes of these stockouts. The main findings from the literature review are that stockouts in medical commodities and equipment supplies generally result from the inability to manage supplies, including reporting shortages and taking effective actions to prevent recurring stockouts. So those responsibilities are normally on the heads of pharmacy in a district, in a tertiary, secondary hospital, pharmacy assistants at the primary level, and also, of course, you know, when there aren't pharmacists and there are nurses of any kind who are doing the stock intakes, because of shortages in particularly trained health workers. So in conclusion, this research shows that stockouts of especially injectable and external condoms are ongoing. This remains a serious challenge. As I mentioned before, over 45% of all contraceptive users use injectables in South Africa. This data is quoting from the National Department of Health in 2019. And again, from literature from Modesekeng and his colleagues in 2020, as well as Magzari and their colleagues in 2017, they argue that reliance on limited global supplies and international producers escalates risk of contraceptives, stockouts in general from poor planning. It's important to note that this was exacerbated by the COVID pandemic. And under the conditions of contraceptive shortage, clinicians can only recommend what is available. If an injection isn't available, they might suggest an implant or they might suggest pills. However, this undermines women's reproductive rights and it causes the state to fail to comply with its obligations. Lack of truly free contraceptive choice can increase women's need for abortion services. In terms of abortion, the majority of primary care facilities surveyed refer users to other facilities for abortion services. This is very crucial and important to understand. What does that mean in terms of this kind of service and the need that people have for it? This likely increases individual costs, such as transportation that patients are putting out, loss of wages in terms of leaving work, loss of school if one is studying. It likely also prolongs the unsupportable pregnancy and can increase social costs. So for example, if referrals take a long time, it takes time for the person to be able to access other facilities, the cost to the health system for more second trimester services and hospital admissions would add to those social costs. These results show a gap between the law, policy, and reality of lived experience, especially if you are an adolescent, economically disenfranchised girl, young woman, or pregnant person. Thank you for allowing me to share these insights with you. I look forward to any questions that you may have.
Thank you so much, Jess. That is really, it's really highlights for me the need for making sure that things are accessible, not just in terms of having stock, but also in terms of just being able to access them. You were talking about the financial costs of having to go to other facilities when they're not available. And that really just makes it so hard, especially for people in rural areas, to then access these services. So yeah, thank you so much for your insights on that. I don't know, we have time, I think, for 1 or 2 quick questions, if there are any. If not, just, and you think of something later, just pop it in the chat. I can't see any hands raised. Okay, so if there are any questions for Jess, just pop it in the chat and we can also look at the end in the closing comments. But thank you, Jess, so much for being with us today and for sharing your insights on this topic and the report. Much appreciated. From there, I'm going to move on to our next 2 speakers. So they will be doing a joint presentation. It's Janina Jochem and Abigail Ornelas. And I'm going to just tell you a little bit about them, but they will be talking about the evidence towards a package of care for adolescent mothers in South Africa. Janina is a postdoctoral researcher at the Department of Social Policy and Intervention and a research fellow at Nuffield College at the University of Oxford. She has worked with adolescent mothers since 2017 with a primary focus on the factors that protect their schooling in South Africa, but also works on non-randomized evaluations to identify combinations of interventions to support learning and health outcomes across this population in sub-Saharan Africa. Abigail is a social sciences researcher with a doctorate in social work from Stellenbosch University, South Africa. She has over 8 years of research and project experience spanning across academia, as well as the public and private sphere. She is currently a research officer at the University of Cape Town and project manager of a large-scale randomized control trial on digital parenting app, with a particular focus on cost effectiveness. Her research interests span gender transformative development, mental health, socioeconomic policy, NGO management, and bridging the divide between individual and collective well-being. Ladies, thank you so much for joining us today, and we look forward to your presentation. Over to you.
Thank you so much, Sam. I realize that colleagues, we've had quite a lot of presentations, a lot of information happening. And so I think we can all just take a minute and kind of just shake ourselves out. And while I try and share my screen. Okay, so as Sam said, my name is Abigail and I'm presenting alongside Janina, and we are presenting on behalf of a much, much bigger team. So we don't want to take credit for all of this incredible work. This is work that's been going on for several years with a bunch of incredible people. But we'll be speaking briefly about the evidence behind a package of care for adolescent mothers in South Africa. And so a lot of the previous presentations, the focus has been on preventative work. Our study is different in that we recognize that teenage pregnancy is something that is taking place in South Africa and globally. And so we want to look at how we can best support teenage adolescents, pregnant and parenting adolescents. So just a quick overview, our team spanning across the UK, SA, and particularly located in the Eastern Cape. That's where our fieldwork team is and our head office. Our team is much bigger than this, but these are just a couple of the people that have a particular focus on adolescent mothers. And so I won't go into too much detail here because I think the previous presentations have given us a lot of context. But essentially, 1 in 3 adolescent girls in South Africa become mothers before the age of 20. 40% of school learners do not finish matric. And as we know, school dropout can lead to have several different impacts for adolescents, including impacting their employment opportunities, increased risk for HIV and sexual risk behavior. And we then have 35 to 50% of adolescent mothers do not return to school and then do not finish school. And so to give a brief overview what parenting in adolescence is, the kind of challenges and obstacles that many adolescent parents face. It's this cycle often of early adversity, which then would lead to adolescent pregnancy, which then has implications for schooling, for mental health, physical health, which can then have implications for poverty, for work access, low parenting skills, child development delay, poor child health, and then it just kind of repeats the cycle going back into then early adversity. And so our work was looking at, if we look at this cycle, how can we possibly impact or support young mothers when it comes to school dropout, when it comes to mental health and physical health, so that we can at some point try and interject and put an end to this cycle that contributes to this phenomenon. And just quickly, this Hey Baby study has been 5 years of following up with adolescent mothers and their children. So just over 1,000 mothers, just over 1,000 children. And for 5 years, we've been looking at their health and their well-being. This hasn't been an intervention study, but it's been focused on just following and monitoring these adolescents, checking in with them and finding out where are they succeeding, where are their challenges, what services are they accessing, etc. And so we started in 2018 and then did additional follow-up in 2021, and now additional follow-up with the mothers and their children in 2024. And about 30% of the adolescent mothers that we are working with are living with HIV. And you can see there on the right, this is where the mothers have been sampled from. So they are predominantly in the Eastern Cape and have come from other studies, one particularly called Mzansi Wako, and then also from door-to-door clinics, peer referral schools, etc. I'm now going to hand over to Janina, who's going to take us through some of the numbers and the incredible work that's been done.
Great, thanks, Abigail. I'll give a brief overview of the sample and then talk about some of the findings. In the spirit of today and the theme, I'll start by saying that 30% of the mothers in our sample were classed from being from rural communities, and the very vast majority of pregnancies was unintended, as we've heard in many of the other presentations before. However, 10% had already had more than one child under the age of 19 within our sample. In terms of service access, including antenatal care, it was quite varied, but what's perhaps standing out here is we have also information on the children of the adolescent mothers is only about half of them at the time of the interview had been fully vaccinated. The area that we think started to explore quite early on is school enrollment, as that's often raised as a major concern for the future of the mothers themselves, but also for their children. We've heard it like several times earlier today. And we were kind of surprised that unlike we expected, many of the mothers, about 90%, were actually still enrolled in school when they first became pregnant. So in terms of finding ways to reach them and connect them to services and kind of address some of the health and other needs that they might have, we found, at least from our sample, we would know how to find them. And we were kind of trying to find how to use schools as kind of connective centers to link them to other services. However, about a quarter of the girls in our sample said that at some point during the pregnancy, they left school, many of them quite early on. So as soon as they found out that they are pregnant, they left school, potentially related to trying to avoid the stigma that they often receive in that context. And luckily, many of them returned, about 70%. It also means 30% didn't return by the time that we interviewed them, but the majority of them had very small children under the age of a year. So there's potential for them to come back. And the ones that did return to school again came back very early, within the first, I think the earliest was 7 days after she's had the child, and the majority was within the 8 weeks of giving birth. Next slide, please. The the next few things that we looked at was kind of what are the factors that are linked to leaving school during pregnancy and coming back. There are a few that are important for both, such as household poverty, and what potentially stood out as how different stages of pre-pregnancy, pregnancy, and what happens afterwards are linked. So the girls that were already not doing as well as others in terms of, you know, having repeated a grade or several grades, they were much more likely to leave school early on, and they were also much less likely, sorry, to return. In this slide, one of the strongest variables that was linked to going back to school was how much childcare they have available after the child is born to help them. So quite a practical element in their lives. That includes informal childcare from their own caregivers or aunties or other family members. But the variable standing out most was access to and use of formal childcare services in the community, so creches and childcare centers. And the mothers that used those were over 4 times more likely to have gone back to school than those who didn't use those. Next slide, please. So as Abigail mentioned, the idea here was to move towards finding a relatively simple and feasible and practical package of care with kind of provisions that in combinations have multiple positive effects on these girls. So not just one area of positive outcomes, and what that means I'll explain now. So here, for example, one of our colleagues started looking at the effects of food security, so having enough to eat in any given week, on multiple HIV risk outcomes here, such as transactional sex, alcohol use, and so on. And so the way you would understand this type of diagram is that somebody who's food secure compared to somebody who isn't, for example, has a reduction of transactional sex from 16% to 3%. And then you can see all of the other different HIV risk outcomes in bold would also show positive impacts. Next slides. So we heard before, childcare was really important for returning to school, but in terms of the ultimate goal to find a care package with different practical ingredients, we also wanted to see what other positive outcomes childcare could bring. So we looked at a number of outcomes, including school, but also how the mother feels about the future, what's the parenting that the child receives from the mother, and the child development. And this graph shows that having access to childcare, we showed, like, improves multiple of these different outcomes, not only for the mother, but also for the child. Next slide, please. And I just wanted to put this slide here just to highlight a few more details of childcare. And we haven't looked at all of the different information that we have, but just because childcare stood out as such a strong variable in the data set that we looked at, but it kind of surprised us that childcare is often discussed when it comes to adult mothers and access to universal childcare, helping them to return to employment and their earning potential and these type of things. But there's very little information, like practical, useful information on the role of childcare for adolescent parents. And just some numbers here of the 25% of mothers that do say they use it in our sample. They use it for quite a lot of the week, so all day, every day during the week, their kids go into childcare for only an average cost of 150 Rand a month. It's not that much, so we definitely thought that's something worth exploring more, given the multiple benefits for mothers and children, not just for school, but also for child development potential and the other outcomes that we've seen. Next slide, please. And this is moving towards a scenario where we are combining these individual ingredients that we talked about, like food security and childcare, and we've run a sort of larger analysis that looked at further outcomes, including, you can see here, different violence outcomes. We heard earlier that that's a huge issue in this group. To come up with sort of the bare minimum of ingredients for a care package, which here includes food security, parenting that they receive from their own caregivers, so nonviolent parenting, in other words, having a good relationship within the family unit, and then access to respectful clinics. You will notice childcare hasn't made it into this package, but that's just because childcare is particularly important for returning to school. But to reiterate, the goal here was to find some ingredients that affect all of these different outcomes at the same time. And we can move to the final slide. Actually, I should say one thing. So this is just results from South Africa, but we're privileged to have the same information from other sub-Saharan African countries, so we can test if that'll replicate or like what the different ingredients will look like in other countries. And this is the final slide, and it's just to show what we're doing with these slides. Again, multiple people previously have mentioned the kind of experiencing obstacles with school-based support teams and kind of other members, not necessarily just principals or teachers, but other kind of community members that are a little bit wary of teenage pregnancy and supporting this group. So what we've done over the past, I think, 12 months or 18 months is we've translated many of the findings that we've presented to you here into nice, accessible, they're nice and accessible to me, people can disagree, kind of comic strips, and they engage different groups. So that includes pregnant girls and adolescent mothers themselves, also teachers, and but also other school-based groups. So there was the Council of Learners and different school governing boards and different groups that have been previously highlighted as potential obstacles. And the goal here was to see what these groups think of these findings and what solutions do they think are suggested by those findings, and what can we do to co-develop solutions to help this group. And I think one of our colleagues who was very instrumental in this is in the audience. So this is our last slide. We are happy to answer questions, Abigail and me, and also Mildred, who is in the audience. Thank you.
Thank you so much, Janina and Abigail. Are there any questions from the audience? So just from my side, a quick question. A lot of the things that you're talking about obviously are huge social problems that, like things like food security and poverty and that sort of thing. Is your study including any recommendations in terms of how to, like in that package of care, how to address such massive problems like that?
Yeah, I think as I said previously, the primary goal of the research was to, for me at least, was to use existing services and see where the way that I'm imagining it is often there are different train stations of support that are already existing, but they are often not connected with kind of train tracks properly. So I think in the way we thought about this initially was to just say, there are so many great community support services around. It might just be a way of connecting these better and using schools. But then, as we've heard earlier, schools are often not very happy to be part of that role. And it's a capacity issue as well. So that's where I think we initially started to, and how these workshop groups that I was talking about come in to see there must be some ways. Maybe it's not going to be perfect, but maybe some improvement in the short term. I think you're asking about food security, and I agree with you. I think the way that we would usually see about reaching food security would be about grant and grant access. So I think for adolescent mothers, and I think Mildred can speak to this much more because she just sent me something on this yesterday. But it's just getting adolescent mothers, the child support care grant is often attached to all sorts of issues. So it becomes more kind of like removing barriers for the specific group that either like other groups don't have, or maybe there are unique barriers to this group, and maybe highlighting this as an issue. But Mildred, feel free to improve on what I just try to say.
Abigail, I see you have your hand up. Would you like to go ahead?
Yes, but unless Mildred has anything that she wants to say first.
Hello?
Yes, we can hear you.
Hi. Oh, finally. Okay. Thank you, Janina. And I just want to also thank everyone who has presented. It has been very informative. And just to answer that question, but also give a summary reflection on the presentation that you and Abby were doing right now, is that the last slide was speaking about ways forward, and it's all focusing on like a care package for young adolescent mothers. So in terms of food security, it came as one of the ingredients that can best support adolescent mothers in terms of their schooling and also enhancing their life for better future. But also to emphasize that throughout all these years of research and just learning more and more about SRHR and teenage pregnancies, we also came to understand and also observe in field on all the components that take place in research, that young mothers or adolescent mothers also need a bit of awareness, or need all of us, especially in this Department of Health, where we can also not overlook how much emphasis is only solely relying on them. And what I mean by that is that, for an example, if we can talk about the education around SRHR and looking at how the approaches and methodologies out there targets young girls and young women only, it's a responsibility that if we are speaking about care package or support, it needs to be inclusive. And what I mean by that, we see from data that there's less evidence around men's health and boys. And I think there's less, and we can all agree that not all young or teenage boys and young men have sex to make babies. So there is that gap where the inclusion of young men and teenage boys when it comes to SRHR education should be increased and should be looked, and this needs to be more sanitization and awareness when it comes to the inclusion of young men, and not only for the betterment of young men, but also to best support young adolescent mothers, where we are introducing interventions or awareness that doesn't solely rely heavily on them to take or be responsible for. But when we include the communities, I think going way forward, or other interests that we can all start thinking around and introduce new approaches, is to include other people that can help best help these interventions or these suggestions or these approaches, not to heavily rely solely on young teenage girls alone, where they can partner up either with their parents, their partners, their peers, where all these things can be handled in a very more holistic manner. And not to take too much time, but I just wanted to end on that note and hand it over to Abby just to finalize on some of the things I might have left out. But thank you, everyone. It's been very informative.
Thanks so much, Mildred. And I will just be really quick then, I think, because you definitely raised a lot of really amazing stuff there. The last thing I'll say is just, Sam, around the question about food security and addressing those bigger issues. I think that the main sort of focus for us is that we wanted to isolate and highlight, okay, adolescent pregnancy can start to become quite an overwhelming thing, as we've heard from all of these presentations. There are so many different components, so many different ways for us to look at it, so many different things for us to address. And this can often result, particularly at the kind of policy level, into a sort of freeze reaction, where it just starts to become too big and too complex. And then, like Janina said, there's these train tracks that are just missing each other. And so I think our focus was to go, okay, at a bare minimum, if you were to address these three things, this is evidence-based, is that food security, etc. These three things alone could have a drastic impact. And then obviously to add on to that and complement that with additional services. But if you were to just critically address something like food security, the impact that you could have is massive, and it just makes it more feasible to start to approach the problem, as opposed to just looking at this myriad of issues and suddenly feeling quite overwhelmed by it.
Yeah, thank you. So yeah, I've that's such a interesting and I think a very useful approach, because I think a lot of the time, especially in civil society sort of spaces, we're addressing issues that are so huge and so overwhelming, and you know, if we look at the things that you can do, it can kind of take people out of that space of like the fight or flight mode, and we can't do anything. And so let's focus on the things that we can do, and like you say, the packages that we can offer that are going to have a huge difference. So I think, yeah, that's totally in line with how RAP views interventions. So I'm yeah, grateful that you guys were able to present that to us today. Thank you to everybody who's presented and everybody who's participated. We really appreciate you taking the time out to be here today. For me, it just highlights, as we've gone through all these presentations, it just highlights to me how important it is that we have this intersectoral approach, that we have like almost like a whole of community, a whole of society approach to addressing this problem, and like everybody just playing the part that they can play in supporting young girls. Because it is crucial for their economic future and for their educational future, and for them just being able to reach the aspirations that they want in their own lives. And that then being able to raise their families and to contribute in a constructive way to society. So it's really, really crucial on so many levels. So thank you to everybody. Thank you to all our presenters who were here and took the time out to be here today. We're really grateful. We hope we can collaborate with you again in the future. And yeah, I think with that, I'm going to bring this webinar to a close. I hope you've all enjoyed it. And as Judy X says, I'm just going to steal her ending. Let's start.